Hello and welcome everyone. I'm Dr. Ishrat Sabareen. On behalf of StarMed Medical Education Program, in the next couple of minutes, I'm going to discuss the acute pericarditis in the context of NAC OSCE examination. So let's begin. The learning objectives for today has been divided into three parts. The first part includes a quick review of acute pericarditis. Here we will discuss the definition and the timeline of acute pericarditis, the common signs, symptoms, common complications, the risk factors, the differentials, physical examination findings, the investigations, and the management. The second part includes a practice case. We will discuss about how a door information look like and how to make best use of the golden 2 minutes before we enter the room. We will also discuss about the history-taking format and how to summarize a case. The last part includes ECG interpretation of acute pericarditis, the common post and counter questions, and also the case variations. So what is pericarditis? It is an inflammation of the pericardium, which is the thin sac that surrounds the heart. Acute pericarditis generally lasts less than 4 to 6 weeks. Common presenting symptoms are chest pain, shortness of breath, palpitation, and cough. And the common complications are pericardial effusion, cardiac tamponade, recurrent episodes of pericarditis, atrial arrhythmia, and constrictive pericarditis. The most common cause of acute pericarditis is recent flu. The other causes include medications, for example, antituberculous and immunosuppressive medications. There are other causes too, for example, history of surgery, heart attack, kidney disease, tuberculosis, and autoimmune conditions. The differentials of acute pericarditis are acute coronary syndrome, pulmonary embolism, pneumonia, and musculoskeletal causes. Acute pericarditis is a clinical diagnosis. However, we will run some investigation to confirm our diagnosis and rule out the others. Whenever we are ordering any investigation, we need to ask ourselves how these investigations are going to help us. Let's have a quick look at this example. CBC with differentials will be as a baseline investigations. However, it will also help us to rule out pneumonia. CRP and ESR will rule out inflammatory conditions and autoimmune disease initially. ECG will rule out pericarditis and acute coronary syndrome. Cardiac enzyme will rule out acute coronary syndrome as well. Chest X-ray is going to help us by ruling out pneumonia. In addition, echo will rule out the complications of acute pericarditis, which is pericardial effusion, and D-dimer is going to rule out one of our differentials, which is pulmonary embolism. The only pertinent positive finding is a friction rub. However, it is present only in 30% of patients. The other physical examinations, which is pulsus paradoxus, edema, Kussmaul sign, will be absent. In this case, blood pressure will be normal. Jugular venous distension and organomegaly will be absent. Other physical exam, for example, malaise, sinus tachycardia, low-grade fever, may be present, may not be present. The non-cardiac finding, if acute pericarditis is related to a systemic condition, you can find rash, arthritis, weight loss, and night sweats as well. In terms of managing a patient with acute pericarditis, always ask for vitals. Now the question is why? It's very simple. If the patient is vitally stable, you can treat the patient as an OPD patient. However, if the patient is vitally unstable, you need to admit the patient, stabilize, call for urgent and emergent consultation, and treat the patient. In terms of treating the chest pain, you can start with NSAIDs and steroids. Colchicine can be applied if there is reoccurrence of the chest pain. Do not forget to treat the cause of the acute pericarditis. For example, whatever the cause and risk factors we have mentioned in our previous slides, if there is any, please treat them. Inform the patient regarding the possible side effects of the medication. Set up a follow-up appointment with the patient. And definitely educate the patient regarding possible changes in the pattern of pain. In case the pain gets worse, advise the patient to come back to the clinic or ER or call 911. So let's practice a case that we might get in the NAC OSCE exam. You might find a candidate instruction on the door in the day of NAC OSCE examination like this. A 40-year-old male, Peter Morgan, presented in the ER with complaint of chest pain. In the next 8 minutes, obtain a focused and relevant history. Do not perform a physical examination. At 8 minutes mark, the examiner will ask you some questions. Once you get the scenario, you will get the golden 2 minutes, that is 120 seconds, before you enter the room. So what should you do in this 120 seconds? Make the best use of it. Now the question is how? There are a lot of strategies you can apply in this 120 seconds. Regardless of whatever strategy you choose for yourself, do not forget to write down the differentials on your booklet before you enter the room. The good to do is to write the history structure. We will talk about it after a while. And nice to do is to write the investigation and management plan, which we have already discussed. Does it sound a bit overwhelming? Trust me, it is doable. With everyday practice, you can master this strategy within only 90 seconds. Now let's talk about the history structure itself. Based on the information we have gathered from the previous slide of the practice case, we can divide our history structure into 3 simple steps. Step 1 includes onset, setting, course frequency, duration, and PQRST. In step 2, we have ARA, which means aggravating factor, relieving factor, and associated symptoms. We also have constitutionals, differentials, red flags, and risk factors. Thus, step 3 includes a mnemonic which is called PAM-HUGS-FOS, which we will discuss in our later slides. So let's start with the step 1 of the history structure. We have onset, setting, course frequency, duration, and PQRST, which means position, quality, radiation, severity, timing, and trigger of the pain. Usually, the acute pericarditis chest pain has sudden onset. The quality of the pain is sharp, it radiates to the back, it changes with position and breathing. So what questions we need to ask here? On onset and setting, we can ask, when did it start? How did it start? What were you doing at that time? For course, we can ask, is this the first time? Since the onset, is it the same or getting worse? For duration, we can ask, since it started, is it on and off or all the time there? If it's on and off, we can definitely ask about how long each episode lasts. While elaborating the PQRST, we can ask, can you point with your one finger where the pain is? Can you describe the pain for me? Does it go anywhere? On a scale of 1 to 10, where 10 is the worst, how do you rate the pain? For timing and trigger, you can ask, is it related to any time of the day? And what brings it on? Once we are done with the step 1 questions, we will move on to the step 2, which is aggravating factor, what makes it worse? Relieving factor, have you tried anything or noticed anything that relieves your pain? Associated symptoms, for example, racing of your heartbeat, difficulty in breathing, and cough. Typically, an acute pericarditis gets worse on lying down, coughing, deep breathing, and it gets better while leaning forward and sitting up. By this time, you will already know that it is a pleuritic pain, most likely acute pericarditis. Now, the next task is to rule out the other pleuritic pain, which is the DDs, and the red flags and also the risk factors of acute pericarditis. A very important point to remember over here is always ask about the constitutionals and red flags, even if you know the diagnosis early on. For the constitutional symptoms, we need to ask about the weight changes, appetite changes, night sweats, lumps and bumps anywhere, bleeding from anywhere, repeated infections, bowel and bladder habit. Constitutional symptoms are lifesaver and game changer. Whenever in any NAC OSCE station, if you get stuck or you get blank, these questions will really help you to narrow down your diagnosis. The next is to rule out the red flags and the differentials. For the pulmonary embolism, you're going to ask questions like any personal or family history of clotting disease. If it's a female patient, you can ask about the OCP or HRT. You can also ask about long-haul flights and other questions which are related to pulmonary embolism. To rule out acute coronary syndrome, the questions might include the history of high blood pressure, diabetes, cholesterol, recent stress, lifestyle such as exercise, food, weight, cocaine, alcohol, smoking, recreational drugs, family history of cardiac death before the age of 50. For pneumonia, you can ask about fever, cough with phlegm. For the musculoskeletal causes, you can ask about any trauma to the chest. Finally, you will move on to the step 3 of your history structure, which is PAM, HUGS, FOS. If you have missed anything earlier, you can definitely ask it here. So let's decode what the mnemonic PAM, HUGS, FOS stands for. P stands for past medical history. Here you can ask any recent flu, heart attack, kidney disease, autoimmune disease, tuberculosis history, if you haven't asked it earlier. A stands for allergy to any medication or any other allergies. M stands for medication history. Here you can ask about any anti-tuberculosis medication, immunosuppressive drugs, or any other over-the-counter medication. H stands for hospitalization. You can ask about the recent surgeries. U stands for urinary habit. If you haven't asked it in the constitutional symptoms, you can definitely ask it here. G stands for gut or bowel habit. Again, if you haven't asked it earlier, you can ask it here now. S stands for sexual history. F stands for family history. O for occupation or the support, particularly the financial support. S stands for suicide and mood. And the last S stands for smoking, alcohol, and recreational drugs. Once you are done with your 3-step history structured questions, you might find that the 8 minutes is over, and the examiner might ask you to present your case or summarize the case. Remember to include all the positive points and all the important negative points that you have gathered while you are asking questions to the patient. Here is a sample answer for you. You can pause the video at this point, read it on your own, and practice presenting or summarizing the case with your study partner. You need to remember the characteristic ECG changes in acute pericarditis. There will be widespread concave ST elevation and PR depression throughout most of the limb leads and precordial leads. There can be reciprocal ST depression and PR elevation in lead AVR with or without lead V1. Sinus tachycardia is also common in acute pericarditis due to pain and/or pericardial effusion. Here is a sample ECG of acute pericarditis. You can definitely Google for more ECGs, get yourself familiar with the changes, and practice reading out those ECGs with your study partner. In this slide, you will get an idea about what kind of post-encounter questions you might face in NAC OSCE exam. They are very common, yet you need to master them very well. One of the questions is, what is your diagnosis? What are your differentials? what investigations you would do at this point, how are you going to manage this patient. You might get a couple of case variations for acute pericarditis. For example, it can be focused history, history and physical examination, history, physical examination, and counseling or management. It can appear as only a history and counseling stations. I have mentioned the time slots. These are all sample case variations, so you can keep in your mind that you need to be prepared for all kind of case variation that can appear in NAC OSCE exam. So this is the list of resources and references I have used to prepare this presentation. I will highly recommend all of you to visit the mcc.ca website to have a better understanding of the NAC OSCE exam in terms of preparation. Thank you very much for bearing with me, and I wish all of you all the very best for your NAC OSCE exam.